Ladies and gentlemen, may I have your attention please? मैं खुद ज़मी हूँ मगर ज़र्फ़ आसमां का है, मैं खुद ज़मी हूँ मगर ज़र्फ़ आसमां का है कि टूट कर भी मेरा हौसला चटां का है। ये और बात है कि अदालत है बेखबर वरना, ये और बात है कि अदालत है बेखबर वरना तमाम शहर में चर्चा मेरे बयां का है।
बिस्मिल्लाहिर्रहमानिर्रहीम। शुरू अल्लाह के नाम से जो निहायत रहम वाला है। Dear distinguished guests, honorable invitees, and ladies and gentlemen, Assalamu alaikum, and a very good morning to all of you.
Myself Rabil Kadir from final year BDS,
And I am Zainul Abdeen from second year BDS, and we shall be your hosts for today's event.
it gives us immense pleasure to welcome you all at the 5th LUMHS and 9th International Dental Conference, organized by Faculty of Dentistry, Liaquat University of Medical and Health Sciences Jamshoro, in collaboration with Pakistan Prosthodontics Association.
We are extremely honored to have with us today an elite panel of guests. We also have with us today prominent and notable experts in dental health, who shall share their expertise with us shortly in the form of inaugural, keynote, and thematic lectures. After this inaugural ceremony today, on behalf of the organizers and collaborators, we would like to extend our heartfelt greeting to all dignitaries of today's event.
We at 5th LUMHS and 9th PPA International Dental Conference are committed to enhance the scientific knowledge and to deliver an enriching experience to our delegates. The conference aims to bring together not only national and international dental health speakers, but also experts from all other fields of health sciences, because we believe that it is a true way forward for promoting dental health and achieving sustainable growth in the neglected field of dentistry.
Ladies and gentlemen, on this occasion, the Institute of Dentistry, Liaquat University of Medical Health Science, is also conducting its workshops on various titles, supported by Pakistan Prosthodontic Association. The conference also includes a dental trade exhibition, poster competition, souvenir ceremony, along with colorful gala night.
Organization of this event is a fruit of combined efforts and incessant hard work of the pillars of Institute of Dentistry, that this event has been a huge success today. नहीं है ना उम्मीद इकबाल अपनी कष्ट वीरां से, नहीं है ना उम्मीद इकबाल अपनी कष्ट वीरां से, जरा नम हो तो ये मट्टी बड़ी जरखेज है साकी.
Ladies and gentlemen, we will now call the panel of experts for first scientific session to please come on stage and take their respective seats. Respected Professor Dr. Abdul Ghani Pathan, Professor of Operative Dentistry, ex-chairman of Operative Department LUMHS, and ex-principal of Bhitai Medical and Dental College, Mirpur Khas. Sir, please come up on stage and take your respected seat. He has not arrived yet, so I will call next panel of experts.
Respected Professor Riaz Ahmad Waraij, Professor and Head of Oral and Maxillofacial Surgery, University of Lahore, and he is also President of Pakistan Association of Oral and Maxillofacial Surgery. Please, sir, kindly come on stage and take your respective seat.
Respected Dr. Maqsood Ahmad Sumro, Head of Prosthodontic Department, ISRA Dental College, ISRA University, Hyderabad. Sir, please come up on stage and take your respective seat.
We would now proceed to our first lecture of today's scientific program. To deliver first lecture on overview of implants in aesthetic zone, I would like to invite Professor Nazia Yazdani. She is the Advisor Academics, Director of Postgraduate Medical and Dental Programs, Fatma Memorial School of Health Sciences, Lahore. Country Representative, Asian Academy of Prosthodontics, International Advisor, Royal College of Physicians and Surgeons. She is also the founder member of Pakistan Prosthodontics Association. Please, ma'am, come on stage.
Bismillahirrahmanirrahim. Mr. Chairman, fellow colleagues, dear students, ladies and gentlemen, Assalamu alaikum. I really feel very honored and privileged to be a part of this August event. Pakistan Prosthodontic Association has progressed in a very short time to this stage that we are Allah miyan chota kad bhi na de. So we started this journey in 2012, and alhamdulillah, in 22, we are today celebrating and also presenting our 9th International PPA Conference. Everyone who has been involved, I have great respect, regard, and love for them. And I would like to thank on this occasion the organizers of this event, Professor Amir Bhatt, his team, and of course, the LUMHS University, the Vice Chancellor, who have been very instrumental to make this event happen. I wish you all the best and good luck for all future programs, and I'm sure that this would also be a great event, a memorable one. Before I start my presentation, I would like to dedicate this to the ever-loving memory of Professor B.A. Yazdani. He was a legend, a teacher, a mentor, a great friend, a very loving, caring, humane person, and above all, my inspiration, the reason for me being here, my role model, and of course, my very loving father. May Allah bless him eternal peace, because the support of both the parents have been so much instrumental in my achieving all these achievements, of course, after the blessing of Allah Almighty. And may they have the highest ranks in Jannatul Firdaus. Ameen. The topic of my presentation is an overview of the dental implants in the aesthetic zone. A lot has been read and has been said about this, but every time you find that there is something which you would like to share with others. We all know that this aesthetic zone, because this is the most aesthetically visual area, therefore it has its challenges and it is difficult too. But the people have opted for implant placements because they find that it gives a natural appearance, and also it has an expected longevity. To achieve all this, we need to have a good understanding of the anatomical, biological, surgical, and the prosthodontic principles. Although the results, they are very easy to predict, but at the same time, what the patient's demands and functional requirements are, they have to be fulfilled. For this, there are three most important elements. One is the hard tissue, The other is the soft tissue, which is the architecture. And most importantly, the placement and positioning of implant, which have to be prosthetically driven. Implants are not only about drilling holes and placing screws. That's what you can see in this picture. But the reason why I say this is a very important point I would like to emphasize. This patient came and she said, I want teeth. She never wanted implants. She says, I want teeth. And it was just very amazing when she said to why she wants teeth, because when you look into the mouth, what you see that she already has 2 implants which are unrestored. And the reason for that is this situation. So it is not like placing the implants and you can get away with it, but you have to plan and evaluate the patient before you venture on this journey. And this was her comment that I want teeth, I don't want implants. Well, Magni and Balser, they have given us a long list of the fundamental objectives of the aesthetic criteria. They are both related to the hard and the soft tissues, and we have to give attention to all these factors. So therefore, the goals for aesthetic dentistry are that you need to harmonize with the frame of the smile, harmonize it with the face, and most importantly, with that individual. And to achieve this result, as I earlier said, the hard and the soft tissues together, they provide harmony and balance. So what is the challenge? Challenge is this patient who had the central incisor restored with an implant. But if you look at this patient, aesthetically, there are so many problems. Though the implant is healthy, stable, and well integrated, the patient is not happy with the outcome. If you look at this one, you find that the gingival contour, the gingival zenith, the contact point, the papillary discrepancy, and the black triangle, they're all present there. So therefore, what is important is that where do you need to position your implants? Ideally, it should be positioned in 3 dimensions. And it should keep away like 2 to 3 millimeters from the buccal bone. But at the same time, the ideal position of the implant, it depends upon the crown location, design of the implant, and the design of the abutment. And in positioning it, it has to be according to the facial, to the facial position of the crown of the adjacent teeth. The reason that these implants must be placed so that the abutment that you're going to put later on resembles the preparation of the natural tooth and the angulation of the natural tooth. But if they are poorly angulated, then obviously we do have a trick up our sleeve. We can put an angulated abutment, but then poor angulation has its own problems. So when we place an implant, it should be placed like 1.5 to 2 millimeters palatal to the incisal margins of the maxillary central incisors. And as I said earlier on, it should be inserted leaving at least 2 millimeters of the buccal bone. And in the mesiodistal positioning, it is important that we need to evaluate this so that we can select the proper size implant so that we can have a good aesthetic outcome, and most importantly, the preservation of the interdental bone and the papilla. When we place the teeth, the implant, adjacent to the natural tooth, there should be at least 1.5 millimeter bone. And when placing the two implants, the inter-implant distance should be about 3 millimeters so that we can achieve the desired aesthetic outcomes. And if you place the implant in an incorrect position, in the bucco-palatal position, you will find that there is the post-extraction resorption of that bundle bone, and at the same time, there is the risk of the mucosal recession, which you will not appreciate later on. So I think a good connective tissue graft may be the answer to that. If we place the buccolingual position, of course, that too has to be followed according to the presence of the adjacent teeth. If none of this is present, you will find the consequences in the form of a compromised aesthetics, dissatisfied patient, and an upset patient. So most importantly is implant positioning, placement, and angulation. Another important factor that we need to take into account is the apical coronal positioning of that. And it is nothing but just aesthetics versus the biology or the architecture, that how well we can do it. Sometimes you do a case on the patient's consistent demand and insistence. This was one of the patients who had these cantilever bridges done long time ago. Maybe more than 25 years ago he had these cantilever bridges. And he lost his lateral incisor. I gave him a partial denture there, but he was never ever happy. He wanted an implant. Putting an implant was not desirable in this case because you can see the periodontal condition of the patient. He was not a good candidate for that. But because of the long association of this patient, because with my father and then later on he became my patient, an implant was given to him. And this implant was, just look at the length. The problem with this implant was that we did not have customized abutments at that time. So therefore, it was only a compromise. And in this compromise, we gave an implant, but the longest abutment that was available at that time, this was done about 12 years ago, and with a pink porcelain to cover up the facial defect. But now the important thing is, how deep should we go? A lot has been said in the literature that it should be 3 millimeter below the apical margin of the crown, and they also say it may be 1 millimeter apical to the cementary enamel junction of the adjacent tooth. We have all the literature to say, but we need to again evaluate the patient and follow these guidelines. Without gingival resection, you will find that the location of this is adjacent tooth. You look at the cementary enamel junction of the adjacent tooth, and that may be your point of reference. And with gingival resection, it would be mid-buccal gingival margin, which can be used as a guide. But if you are doing the work in the clinic, intraoperative check is that you can place your periodontal probes and you can see for yourself visually where you are going to place the implants. Just a few cases to highlight what problems or what you can do for patients. This lady, she came and she was not at all happy with her appearance. She thought that she's showing too much of her teeth. and at the same time, there were some missing teeth as well. And if you look into the oral cavity, you'll be surprised what she had. The radiological examination can vouch for the intraoral presentation which the patient presented with. So it was decided to extract all these teeth which were blowing in the breeze. Only the lower 2 molars on either side were retained. Implants were given to the patient and a complete upper denture because there was very deficient maxillary bone, and this instantly improved the patient's appearance and her confidence level at the same time. So this is what she looked before the rehabilitation, and this is post-rehabilitation. One of my other patients who was been for a long time, she was wearing partial dentures, but now she never wanted to wear anything which was removable. And in the process, she had lost so many of her teeth. And the reason was, again, poor oral hygiene, debilitating teeth, the whole of the dentition, which also warranted extraction. So in her case, there was a total clearance with upper and lower implants provided to her, and as a superstructure, there were 3 bridges. The interior was made in zirconia for aesthetic reasons, and the posteriors in porcelain fused to metal to reduce the cost and also to make the patient more happier. So this is what she looked like with her prosthesis. Then you also come across patients who have had the treatment done, and when they come to you, you look at it and you feel really sorry, because the case that I'm going to talk about is a young girl. She had these implants done while she was like 15 or 16 years old. And she came to me that she was going for her higher studies, and she wanted something because in the process she had lost the 2 implants, and her prosthesis, the fixed prosthesis, was gone. She was most distressed, most unhappy. The time was short, and she wanted to have something more practical and functional. Looking at her prosthesis which she was wearing was a removable denture, like an overdenture. And there was no occlusion. So she was very depressed. You can see from the picture, this is how she came. So whenever we are planning, the most important thing is that we need to begin with the end in mind. This is important, that what is going to be your ultimate thing that is going to come up. Otherwise, if you do not place your implants properly, you may end up with this sort of a picture, which is not at all desirable or acceptable. So what I did was, I gave her telescopic crowns on the implants to increase the vertical height. I had put in here, where we have these cast partials, the occlusal surface I had raised a little bit to increase the OVD, and that helped in improving the vertical height, and the occlusion plane was also adjusted, and she got that denture and was very of this, because when she comes back from her higher education, we will do something more practical for her, because she's only like 23 years of age. patient, you may look at it and you say, oh, it is only one tooth which has to be replaced. But if you look at that, you find that the patient has got an overlap of the central incisor, and this also is slightly overlapped because of the narrow space. The tooth was extracted, and then sometimes if you do not have any surgical splint, you can make use of this dental floss, wrap it around the two adjacent teeth. This would be a good enough guide for you to place your teeth and enough to have your superstructure as well. So this was given to the patient, the implant was placed, and the reason the picture is you can use a narrow implant, but also at the same time you have to look at this length and the platform diameter and also this gingival height, which is very important for the selection of your abutments. So this was done, and the patient, right, okay. So this was given to the patient, but look at the overlap here, because patient thought that his lateral incisor, the contralateral side, was too wide and he cannot have a narrow or tiny little tooth there, so it was overlapped to give a good balance on either side. But if you have a narrow space, orthodontically we can either create space or we can close the space, and that is another procedure, an adjunct procedure, which helps us in giving a good size tooth. Or at the same time, like in the lower, we can use narrow implants. This was another patient whose case was done a long time ago by somebody. She had lost 4 interior teeth. They only gave her 2 and replaced 3 teeth, which looked very odd. So the best thing is that we should replace as many teeth as are lost, so that that could give the balance and a good occlusion. This lady, she also had lost some interiors and some posterior teeth. They were replaced, but the important thing is that we want to establish this contours here as well, so that we can either give ovate or modified ovate pontics. This was one of the most difficult ones, and you can see it because of the deficient bone and the soft tissues. There is a vertical loss of bone.
Madam, 1 minute left.
मुझे आधा घंटा दिया गया, 20 मिनट.
They have informed 20 minutes and 1 minute left.
I'm so sorry. I was given half an hour, so I had prepared it accordingly. I can rush it up, but give me at least 3 minutes, if that is so. But I thought this would interest you because this is your domain. And I thought this is the reason, and you stopped me right at the time when you were to augment it. Right, okay. So I think this is the most difficult one, and if you can put in a vertical graft with a lot of bones, sectioning, thinning out, we can do it. But otherwise, as a prosthodontist, we also have means of improving on this. We can place the implants, and at the same time, we can give pink porcelain to cover up the defect, the deficiency. And this is what the patient was. She was happy as long as she had the fixed prosthesis. Sometimes you have patients, hypodontia patients, you can give them, because she was only concerned about the space which had to be filled. Otherwise, if you look at the patient, you would like that she may go for orthodontic treatment, have it, the spaces closed up, and have another space on the other side so that we can put in her a canine there. Sometimes you come across these black lines and the black triangles, and this is because maybe of the we were unable to put in a good connective tissue graft there, and these are the problems which we come across. But again, we can manage it by using pink porcelain or by putting a gingival graft. We all talk about this also, the pink and the white aesthetics. Like the pink aesthetics, it evaluates soft tissue aesthetics around the implant, and the white aesthetics is the outcome with regard to the quality of the implant crown that we have. This is also a very important subject, but as the time, I don't want to consume more time of the next speaker. So coming to this, the general rules, we need to follow this because these are the part of our dental aesthetics. We need to look at the color, shade, form, midline, gingival contour or the zenith, and then the restoration, any surface characterization which you would like to give, the lip line, the smile line, the buccal corridor, all have to be taken into account. But most importantly is you have to look at the soft tissue, the biotype. It has got thin and there are thick biotype tissues. But there may be factors which may be affecting the soft tissues around it, and those factors are like the biotype I've just mentioned, other provisional restorations, immediate or delayed restorations. These are all very important. But the thing I would like to emphasize is that if you can do a good replacement and you have followed all the aesthetic criteria, then you will get something like this, that where the soft tissue is stabilized and we have restored it to its original glory, and the patient is so happy about it. I did mention about the papilla, the black triangle. I mean, there is a lot in the literature which has been mentioned that how you can get 100% papilla appearance by the vertical distance between the contact point to the alveolar bone, and they have given all the relation between the implant to implant and implant to tooth. This is all in the literature. Then we also talk about the emergence profile. And the one statement that I like the best in this is that it is a border between the surgical and prosthetic worlds. I just thought that it was so beautifully said, and it is so very true that we need to give this to the patient. And for this, obviously, we need to have this was a really a goner. 3 minute रह गए, बस 3 minute रह गए. आपके लिए सबके लिए एक बहुत, this is a very important study which has been carried out. They say, अच्छा, this is not the study. बस ये मेरा खत्म हो जाए. This is a very important study which I think that we were all concerned. There was a time that the gold standard they thought was that the abutment should be like divergent, have a divergent profile. But now they say that it should have a
Thank you, madam. You presented wonderfully and aesthetically it was so pleasant to see your presentation. But I would emphasize that the function is also very, very important because beautiful teeth, if they cannot chew, are useless. So function is also very, very important as far as the side is concerned.
Thank you so much, ma'am, for your befitting words. Due to scheduled time, honorable speakers are humbly requested to complete their presentations in 20 minutes. Thank you.
Ladies and gentlemen, to deliver today's next lecture on efficacy of revascularization to induce apaxification and apaxigenesis in infected, non-vital, immature teeth, I would like to invite Dr. Shade Ahmad Musa. He is postgraduate and clinical doctorate both in pediatric dentistry and oral public health from Al-Azhar University, Egypt. DPH from Royal Australasian College of Dental Surgeon. Consultant and assistant professor in Zagazig University, currently working as a consultant of pediatric dentistry in PHCC, Qatar. So sir, kindly come on stage and deliver your speech.
Interruption about the implant. 80% of the causes to invitation of the implant is the dental caries. So this is a base of the dentistry. The new fashion now is surprised about non-invasive caries removal or management. The non-invasive caries management is a new fashion and a new concept because the caries by the conventional way is the old fashion. We are trying to making a new facilities, techniques, material to deviating our line about the conventional way. Firstly, I am sure to confirm this. I have no any conflict about these techniques or this material. It's evidence-based knowledge. So the caries is to be understanding the pathology of the caries. The pathology of the caries in summarize, because you are putting me in 20 minutes, so I try to be very fast. So the caries is about, it is a concept, the presence of the tooth structure in the aqueous media, including of the saliva, including of the streptococcal mutanus and lactobacillus is karyogenic bacteria. All this with presence of the bright or the fermentable food by the acidogenic bacteria, giving us the traditional way of the caries. So the karyology and the management of the caries of primary molar especially is rapidly changed. Now we have a technique. This technique is not new. Firstly, is called a traumatic restorative technique. This technique is designed firstly for the poor people, remote area, and the primitive area. But now it's considered as a technique we can do it anywhere, especially in the children or elderly patients. Firstly, in 1980, this is a German professor. It's called, is a French, is 1996, is accredited by the World Health Association. This technique takes to bright the front of the dentist visit to potentially away from the routine or the conventional way to be working as by using the handpiece and the Fisher pair, round pair, and making the pain. American Association of Pediatric Dentistry is accredited this technique. After that, is considered this technique may have another modification. Sometimes we can't do our proper work of the removal of the caries or management of our lesion properly. So they are added another technique is called an interim. The interim treatment of a traumatic restorative technique is considered for if you have any patient have a problem, elderly patient, the patient is a child patient, we can't be managed and no facility to making general anesthesia or under conscious sedation or any limitation, at least we are making suppression of the lesion to make the life, because the teeth is considered the part of your lifestyle. Nobody can live with a pain. So the principle of the ART technique is very, very easy. Is any one of us, GP, specialist, undergraduate can do this technique. It depends on the concept. We are deprived the cavity and the lesion from all the correlation and the cofactor which are affecting the caries. Firstly, it's dependent on the minimal intervention and the minimal invasion and the minimal cavity preparation by only the hand instrument. So we should, if we want any technique, any procedure in the industry, any technique or any surgery, you should select your patient. You should understand when you get this technique or if this material is indicated or not indicated. So our indicated is a small lesion and also in public health program. This is a very important. Large lesion sometimes leading to the failure. But the contraindication is considered. If this tooth is extended, have bulbally involved, have a swelling, have a fistula, exposed bulb, painful, continuous, have irreversible pulpitis. Also inaccessible cavity. This is not allow us to properly removing of the caries. This advantage is biologically approach, is very conservative lesion and less trauma after teeth. We are also the infection control because we are less susceptible for instrument also, and the cost effective is very important factor, and also friendly procedure. This is a potential use on the children and fearful patient, and also can using with the elderly patient and home boundary patients. So work environment about the ART. This technique is easy. If you are seeing the steps, what we are doing is very easy to do in your clinic and very fast. So the ART is controlled of the saliva around the tooth and they begin treating as a cotton roll. You should be making its isolation, at least by the simple way, not by using the rubber dam. But if the rubber dam is the best. So all safe demonstration about the tooth to deprive the cavity from to be direct continuity with the oral cavity and the bacteria and the cariogenic bacteria. Then the research that shows the ART are durable and successful conventional restoration. We are using the material of the filling is a glass ionomer. This is our choice. Why? Because the glass ionomer is considered as a tool, as a restorative material, and also considered as one of the type of the preventive measure due to releasing of the fluoride and the effect of fluoride releasing from this material. This is some precaution should be follow the manufacturer about the glass ionomer if using of the powder and liquid, and also don't using the, you should be recapping your bottle of the powder because this may be moisture affecting the powder. And this prevents to undertake the moisture photo component also. And should not more than 13 seconds are used for mixing and mixture. This is very important to making a durable mix for the glass enamel. This is a type of the hand instrument which can we using in our technique. So this is a many step. Firstly, we are removing the caries. Be sure you are removing all the caries of the wall. Don't touching of the base of the cavity. At least we are removing the very bulk area of the caries. Secondly, the caries excavating depending on the size and your instrument. The technique also we can see in the filling. You should be putting the glass enamel by increment to avoid the any air void. Also, the proper condensation using of the some condenser material with a blunt and round material, and should reseal all the bit and fissure around the cavity to allow proper prevention measure. This video maybe summarize what we want to know in this technique, which is very easy. Sorry. No sound? No sound. Yes. No sound. That's it. So we have a problem now in sound of the video. Okay. In this technique, we are trying to putting the two cotton rolls, okay, and making the good proper isolation for the tooth. After we are applying our cavity, it should be condensing by the fingerprint to allow this glass enamel to properly condense it and inside the cavity. So, what is our target from this? Our target to deprive all the cavity and all the lesion from the oral communication and the bacteria. So, we are removing all the excess and the sealed material and checking after that the occlusion if this anything is high. So, secondly technique is depending also on the ART. ART is a very, very simple technique. We can be applied in our clinical. The whole technique. This whole technique by the history, the whole technique is invented by one this is Scotland doctor, which have no facilities and instrument, and she is using the stainless steel crown over the caries teeth without any removal of the caries, by sealing it by the glass enamel. After many research, she finds the very, very success lesion is depending on also this concept. We are deprived the cavity from all saturation and all environmental of the bacteria and carcinogenic bacteria and saliva. The whole technique is not suited for every tooth. It should be indicated. If the success should be careful case selection and the high level of clinical skill. Really. Excellent patient management sometimes is dependent on the cooperation of the patient. So if you are performing this, sometimes we are needing the main problem in the pediatric dentistry, and our dental clinic is the local anesthesia. This technique is allow us don't using local anesthesia. It's only going directly to putting the stainless steel crown with glass enamel, filled with glass enamel, and put directly over the tooth and covering it. The process of fitting crown is quick and non-invasive. It's very the skills here to check the proper size of the crown. If you are well trained to check the proper size of the crown, really, it's very easy. So the crown is sealed over the tooth without any kind of tooth preparation. Local anesthesia is not required. So we are solve about 50% of our problem in pediatric dentistry, and some patient with sometimes a special need patient. So for decades, the conventional technique has been that all the caries there is removal of the tissue. The answer is this: it is worth firstly reviewing how and where the caries begin. So it should be understanding this concept is depend on the pit and fissure allowing to slither and collection of the accumulation of the plaque, including of the bacteria. So there's a very big difference between the pit and fissure area and the buccal wall and smooth wall, because it's self-cleaning. So the accumulation of the plaque, presence of the bacteria, and the presence of the deprived food, which is transformed to fermentable material, leading to the cariogenic acid release, this is what affects. So if we are depriving the tooth from all this environment, it means we are success to make the tooth to be prevented to be extension of this caries lesion. So this is a cycle. If this cycle we try to disrupt or removing any one of this factor, really we are stop the process of the caries. Depending on the time, carbohydrate and cariogenic bacteria and the teeth. If the tooth is be isolated from all this factor, it means the tooth is will be protected. So the caries is not extended. Here we are depending on the deeper layer area is different from the superficial area. So that the deeper area is have not cariogenic, is non-aerobic bacteria. So we are stopping this by putting some sealed material. We are trying to deprive the tooth to be direct communication with the Streptococcus mutanis and Lactobacillus acidophilus. This is a main cariogenic bacteria. So after that, we are extending the effective sealing of the proper crown is affecting this. If the crown is not fit, it means there is a space to enter of the saliva and also transcommunication between the saliva and the environment again with the tooth, so it's the recurrent of the caries. So the seal of the crown is very important factor. So the seal of the tooth is very important to maintain the plaque environment, separation from all the substrate and the bacterial nutrition, and so the bacterial profile carries a change from cariogenic to decariogenic, and the lesion will be not progress. So how to select our case? Indication is non-clinical, non-pulpal involvement tooth. Secondly, tooth have to sufficient tooth structure to support our crown. Number three, the patient cooperation at least to be proper working inside. Our contraindication on the whole technique, the patient is to have a risk of the bacterial endocarditis. So it's very important here to removing all the caries and not to be extending for bulbar involvement. Firstly, the tooth with pulp polyp and the grossly decayed of the molar teeth and teeth with irreversible bulbitis. All this is a contraindication, should not using this technique with them. So the axis of the shape of the tooth contact is a very important. Sometimes we are using a separator if there is no available space in the contact, using as a separator, orthodontic separator to separating between the teeth. Also, we have some technical problems. The technical problem is when you are doing two crowns together, the problem is the contact. So the contact here, try to solve this by making the concave and convex shape. This crown to making concave by using of the plier in this shape, so the tooth can be applying the two crowns together with the proper contact.
2 minutes left. The audience, please keep silence.
So our step is depending on proper checking of our crown. Secondly, also drying the tooth and checking the tooth if there is any food debris. After that, we are placing the proper size of the crown to fit it, separating the contact area. After that, we are pushing our crown and put it. Since I place the crown, it should be placed properly, and we should be hear a tuck sound about this. So once the excess cement has been, should be removed after we are making the pressure, and ask the patient at least to buy 2 minutes about the crown to allow proper sealing and prevent any air voids. If the crown is not sealed successfully, then remove it and using the excavator before the cement. Or if the cement has been set at the high-speed hand piece, can be used to removing it. This is a technique if the failure of first time to putting your crown. Okay. Again. No. Wait. This is our time, not our time. Really, this is a technical problem, that's not from me, but I'm so sorry. I try to summarizing the two technique, and there is other two material I want to talking about it. I will summarizing it. This is a new concept of non-invasive caries removal. Is depending on how to manage the tooth without conventional way. In pediatric dentistry and the elderly dentistry, we should using many techniques like the whole technique and the ART technique, which is accredited by the FDA and the World WDA. So this technique is have an evidence base, and also there is other material. This other material, which I'm well talking, this all giving summary, is a casein peptide phosphate, amorphous calcium phosphate. This is a CBB. CBB is called tooth mousy, which is considered as a lot of highly saturation of the calcium and the phosphorus to making a remineralization. Also, the chemomechanical technique using of some materials, this depending on sodium hypochlorite, we are using this paste on the cavity and making multiple times, put and removing the caries, put this material and removing the caries by excavation multiple times. This multiple to extend to the end of the caries without using any of the conventional rotary material. This technique is very, very successful, especially in some cases. At the end, this is a mechanism of the protect degeneration of the collagen fibers of the dentine, caries dentine, and the removal lesion using the special design for non-invasive hand instrument. These three techniques and material we can using and applicable for the poor area, for health program, and very primitive area, remote area, and also some patient in hospitalization, which you can offering to him the proper treatment. And also in the pediatric dentistry, when the child is uncooperated and there is no facility to allow to him to making a proper treatment under general anesthesia if he needs. Thank you very much.
Thank you so much. It was such an elaborative talk. I request the audience that please keep silence. We are all learned people. If we just wanted to discuss and having a cross talk, there is other places to sit, and if you are sitting in the hall, please concentrate towards the lecture. Thank you so very much.
Thank you so much, sir, for your befitting words.
To deliver next lecture on concepts of basocortical implants and compressive implants, the concept of orthopedic surgery and basal implantology, I would call upon Dr. Adil Abu Shark. Dr. Adil Abu Shark is Master in Medicine, Russia, Clinical Master in Immediate Loading, Germany. International Teacher in Basal Implantology for the International Implant Foundation, Master of Science in Implantology and Dental Surgery at International Medical College, President of International Academy of Cortical Implantology and General Manager of Swiss Dental Centers, Jordan. Sir, please come on the stage.
السلام عليكم. بسم الله والحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم. Really, you are giving me 20 minutes, but I don't think I can finish in 20 minutes because they told me I have to talk 40 minutes, so I don't know what to do. I'll do my best. Of course, I've been practicing basal implants since 12 years now. My lecture title will be Immediate Loading Using Basal Implantology Concepts. Excuse me. Next slide. Which slide will be there? So this will be next slide. Okay. Of course, the definition of dental implants you all know. It's a pneumococcus device that is biocompatible and biofunctional and is placed on or within the bone associated with the oral cavity to provide support for fixed and removable prostheses. Of course, even old Egyptians, they tried to help their patients because you see this operation was done 4,000 years ago. And we also, as dentists or as implantologists, we do our best to help our patient to restore their teeth again. Of course, this case, one patient came to me. As you see conventional implants 8 years ago were done. There is excellent healing, no peri-implantitis I see in these implants, but the patient wants something quickly. So I fixed for him 3 compressive implants, as you see, in just 3 days. Of course, indications for dental implants, generally and edentulous area can be an indication for dental implants. Severely compromised denture bearing area, poor oral mucosal coordination, parafunctional habits, hyperactive gag reflex, unfavorable number of potential abutment teeth, and single tooth loss. Contraindications for dental implants: acute illness, terminal illness, history of IV biphosphonates therapy, pregnancy, severe uncontrolled metabolic diseases, poor oral hygiene status. Why these divisions? Based on our experience, these divisions found in relation to our understanding osseointegration and bone. You know, the problem, all companies who are producing dental implants, especially 2-stage or bullet implants, they always speak about the implant and the implant service. They don't speak about bone. Osseointegration has been defined as direct structural and functional connection between living bone and the service of a load-bearing artificial implant. Our standing related to bone is for somehow little because we concern more on the implant type, shape, and service more than our substrate, the bone. Clinically, osseointegration is the asymptomatic rigid fixation of an alloplastic material in bone with the ability to withstand occlusal forces. Histologically, osseointegration is defined as the direct structural and functional connection between ordered living bone and the surface of a load-bearing implant without interventing soft tissue. Based on our understanding of this concept or this phenomenon, it's important to have or to leave our implants for a period of time, 4 to 6 months in the bone to gain this contact so we can load our implants. This is, of course, basal implants. As you see, it's one-piece implants. It's machine-polished implants. Basal implants are the most advanced implants successful for any condition of bone. It can be used on patients with any bone density and any bone volume. These implants engage the highly dense cortical bone, which has last presently for resorption. Basal bone is present in everyone despite severe bone loss due to gum disease or loss of teeth. As such, they are highly recommended for patients who are in need of bone graft and sinus lift. Basal implants are the modern system of implantology which utilize the basal cortical portion of jaw bones for retention of dental implant, which is designed to accommodate the basal cortical bone regions. The basal implant provides an excellent quality of cortical bone for retention. Basal implants are a single-piece implant. In this implant system, the implant and the abutment are fused to a single piece, which minimizes the failure of implants. Benefits of basal implantology: low degree of invasiveness, one-step procedure that we can extract, put implants and temporarily on the same day, simple repair in case of problems or implant exchange, combination with natural teeth possible within here. Elasticity plays important role, which I don't recommend even this technique because I got bad results in my experience. Combination with implants, an easily manageable system, few components, simple laboratory technique, extremely high success rate. Indications of basal implants: all kinds of situations when several teeth are missing or have to be extracted. When the procedure of two-stage implant placement or bone augmentation has failed, all kinds of bone atrophy in case of very thin ridges, sufficient buccolingual thickness, insufficient bone height. Contraindications, medical conditions. There are a number of medical conditions that preclude the placement of dental implants. Some of these conditions include recent myocardial infarction or cerebrovascular accident, immunosuppression. Medicines, drugs of concern are those utilized in the treatment of cancer, drugs and inhibit blood clotting and biphosphonates. Factors that can affect implant placement: maxillary sinus, inferior alveolar nerve, mandibular canal position, and crest anatomy. Using the exist bone, so you are using free area of resorption, free area of infection. The result is no crater-like bone loss. On the other hand, the implant in the cortical or basal bone, which is harder, stronger, and stiffer than cancellous bone, almost free of resorption, free of infection. Of course, basal implantology was born from both dental implantology and orthopedic surgery. These are orthopedic screws which our colleagues in orthopedic surgery use. And this is basal implants. Both of them, as you see, they are smooth. They are one-piece implants. Of course, basal implants can be also rough surface implants, and they're called compressive implants because they compress the bone so that we can load them immediately. Rationale of using basal implants. Teeth are present in less dense bone portion of the jaw bones called the alveolar bone. This is also known as the critical bone of the jaw. The less dense alveolar or critical bone gradually starts getting resorbed and recedes once the teeth are lost. The bone which ultimately remains after regression of the alveolar bone following loss of the teeth is the basal bone, which lies below the alveolar bone. This basal bone is less prone to bone resorption and infections. It's highly dense, corticalized, and offers excellent support to implants. The conventional implants are placed in the crestal alveolar bone, which comprises bone of less quality and is more prone to resorption. The basal bone is less prone to bone resorption because of its high dense structure. The implants which take support from the basal bone offer an excellent and long-lasting solution for tooth loss. At the same time, load-bearing capacities of the cortical bone are many times higher than those of the spongious bone. Advantages of basal implants. Implants load is being transmitted safely to the free basal bone, while in conventional root form there can be a bacterial attack. There are few chances of peri-implant infections because the implant surface is polished and in a basal implant. Extraction and implant placement can be done in a single appointment, even if the teeth are periodontally infected. The patient's alveolar bone is needed, and there is no need for bone augmentation. All patients have enough basal bone, even if the vertical height is decreased. The treatment duration is also reduced. Immediate loading can be done in a basal implant. There is no edentulous phase and no need for immediate dentures. Advantages of basal implants. Aesthetics is disadvantages. Aesthetics is compromised in replacing a single tooth. Of course, the surgeon should have good knowledge about anatomic structure of the tooth. This is what our colleagues in orthopedic surgery are doing. As you see, there are three main concepts in orthopedic surgery in basal implantology. First, they should do bicortical anchorage, that the implants, as you see, also they put unparalleled implants. Besides, they are splinting these implants with the titanium plates. Comparison between dental implantology and orthopedic surgery. You know, in simple cases, coasting is the most common type of treatment for fractures, but not the only option. Fractures come in many shapes and sizes, therefore requiring individual attention and treatment. Some simple fractures can be treated by costing, while other more serious fractures may need surgical intervention. In conventional implantology, most serious cases whom are very reduced bone supply, so can't be removable, also are not treated by implants because they are not a good candidate. It's absolutely the opposite in the field of orthopedic surgery, where serious cases treated by nails, plates, and screws. As you see, this case was done more than 10 years ago with disc implants. You see, this patient is one of the candidates, which is a serious case that can't wear denture. Also, implantologist said to him, you have no bone to put implant in. Any of you can imagine that he will be excluded from the treatment in the orthopedic surgery because of a serious fracture. In orthopedic surgery, they don't pay attention to the implant surface and the material used to treat the surfaces, which means that the colleagues active in this specialty are successful without them, probably don't trust them. Simply deny any importance in influence to the clinical success. Orthopedic surgery concerning at anchoring the implants in the cortical bone and gaining by cortical anchorage, so the patient now ready to load, not overload his broken side, and no need to wait. In dental implantology, we search for the bad bone. We insert our implants in, so patients have to wait 4 to 6 months or even more if other procedures may be needed before inserting implants. Trusting bone, not implant surface. This is what we call it bicortical anchorage. Another reading of the X-ray of orthopedic surgery, they don't concern too much on the parallelism of the screws, and this is giving more physical anchorage, macro retention. In dental implantology, all our attention is paid towards the emerging profile and parallel dental implants. Immediate loading, now applying the rules of our colleagues in the orthopedic surgery, we are also able to immediately load our implants in the following. Whenever enough bone compression can be achieved, also the implant surface immediate loading become possible. Whenever stable cortical implant anchorage is achieved, immediate loading becoming possible as well. Whenever implants can be splinted, the immediate loading protocol becomes more safe. Immediate loading does not depend on the usage of specific implant surfaces. Woven bone areas near the freshly placed implant doesn't support immediate or early loading. This is what really called bicortical anchorage. As you see these implants, in the second slide, you see that all these implants engaged in the second cortical, as you see.
2 minutes left.
So some cases, as you see, all implants are engaged in the second cortical. Many things maybe we need to speak about also strategic areas, that we have 4 strategic areas on both jaw. So canine area and place of 6 or 7, we should place implants in these areas, also on the upper jaw, in the canine area and in the tuberosity. Even compressive implants, as you see in this case, is treated with compressive implants and distal implants or lingually engaged, like the same way I'm engaging basal implants. I'll try to be fast to show you some cases. So using corticals, a tradition in traumatology, we can get the mechanical retention through the cortically anchorage, the unparallelism implant splinting through the plate. So as you see, even these 2 implants, they are different types, compressive and basal. Even compressive implants can be engaged in the second cortical to achieve more mechanical retention. Another case segment, as you see, all implants are engaged in the second cortical. Now I'll show the lower segments. As you see implants, maybe you look at them, you see them parallel, but if we look, that we see that the implants are placed in different directions. As you see, so it's very important to put the implant unparallel. Then we do the bending, as you see. Then we take impression. See how we are placing lower implants. You see the distal implants, they are lingually engaged, and the implants in the canine area, they are going towards the chin. So you see the direction of the implants. It's too difficult to fix the prosthesis here, but after bending the implants, they will look parallel. As you see, it's easier to take impression. Immediate splinting, this is what we can't do immediately after doing the implanting, because we have to wait for the technician to prepare the bridge, how that affect our implants. It's preferred in basal implantology, smooth implants, to load the implants before remodeling starts in 3 days. But compressive implants can be loaded in 1 week. This is what our colleagues doing and what we are doing. As you see, we are using the same implants, smooth implants. We do bicortical, we do unparalleled implants. The traditional way to osseointegration, slow growth of bone towards the implant surface, healing time necessary, woven bone transforms into osteonal bone. Bone is slowly reaching a high degree of mineralization. The modern way to immediate loading is different. Safe macro mechanic anchorage, load transmitting implant surface are indirect with cortical bone, tilted implants, immediate splinting, compression of spongious bone. Of course, where is the basal bone? This slide is showing the strategic areas and the polygon that everything should be, load transmitting should be inside the polygon. This is the areas where we should on maxilla place our implants: canine area, zygomatico-alveolar region, tuberopterygoid region. Of course, in this slide we see the cortical, lingually and buccally. When we do the lingual engagement and the buccal bypass, very thick, very hard bone. In this slide we can see D1, D2, D3 bone in these areas, and how we can do the buccal bypass. As you see the myeloid rind when we do the lingual engagement, or we do the buccal bypass. This is of course the contact in the prosthesis when we fix on immediate loading in general. It should be in the 4, 5, and the 6. Everything on the lower jaw should be contact on the lingual side, but cusps, and on the upper should be on the palatal. As you see, this is a case presentation for a patient who was boneless, as you see, after trauma. So I placed for him basal implants. As you see, I'm doing palatal bypass to the teeth, and we fixed for him 2 minutes. I'll try to show good things now. I don't know. This is the prosthesis, of course. Another case presentation, how we do the prosthesis. As you see, this is the metatarsial. See the direction in the next slide, the direction of implants on the lower jaw lingually, in the upper jaw, double pterygoid. We even go outside maxilla sometimes to engage the sphenoid bone. If you look at the implants, they are all engaged in the second cortical. See in this slide, distal implants are lingually engaged. They are not parallel. As you see, they are distally. So these the implants, how we take impression with the analog. This is what the technician is doing. The metal trial, again we take bite and we take impression again in the metal trial, and the teeth will be after that. Of course, we have some concepts in the prosthetic part, that wisdom teeth should be extracted, front teeth should be out of occlusion, masticatory table should be maximum 8 millimeters, and there is no high cusps, distal implants should be out of occlusion. There are strict rules in prosthetic part, in basal implantology. We should always splint, even when we put temporary, we should splint in metal bar. It's very important. And to fix with Fuji Plus cement. Only few slides left. This is metal to plastic, metal to porcelain. So I just want, please, half minute to show 2 follow-up cases of mine. This case is already about 11 years follow-up. As you see, the patient was the bad oral hygiene and I extract lower. We placed implants. And even after 11 years, no bone resorption at all. As you see, after 10 years, no bone resorption. The other segment was in 2014 restored. You see in this slide, even part of the implants is outside the bone and the gum because of smoothness of the implant. There is no periimplantitis at all on these implants. As you see, another case. After 4 years follow-up, you see no recision, no bone resorption at basal implants at all. And thank you very much for your attention.
Thank you so much. You have completed the whole subject which you really teach the students in 1 year. You are trying to teach us half an hour. That's very good. And you compare the orthopedic surgery and implant surgery. It's also very good because there were 2 topics which you were comparing. So thank you so very much. Next.
Thank you very much, sir, for your essential lecture.
Ladies and gentlemen, to deliver today's next lecture, an overview of recent methods of orthodontic treatment of cleft, lip and palate patients in Pakistan, I would like to invite Professor Dr. Ambreen Afzal Hassan. She is a Dean of Academics and Professor of Orthodontic Department at LUMHS Institute of Dental Medicine, Dean of Dentistry, CPSP. She is also the first counselor from dentistry in CPSP. Currently, she holds the position of Director, National Residency Program, Dentistry in CPSP. So kindly, ma'am, come on stage and deliver your lecture.
अस्सलाम वालेकुम एवरीवन। जब तक टाइम अभी शुरू तो नहीं हुआ, असल में ऐसा बेइज्जती प्रोग्राम होता है हमें आधा घंटा दिया गया और 20 मिनट में, तो अभी मेरा टाइम शुरू नहीं हुआ जब तक मेरी स्लाइड नहीं आती। उस वक्त तक लेट मी सी रिस्पेक्टेड चेयरमैन प्रोफेसर रियाज बड़ाइज, सुमरो साहब, हमारे काउंसलर यहाँ पे CPSP के प्रोफेसर शाहिद परवेज़, मैडम नाजिया, स्लाइड शुरू कर दो, डॉक्टर अहमद, डॉक्टर अदील, डॉक्टर उज़मा, जिनको मैं देख रही हूँ, एंड माय ऑडियंस स्टूडेंट, वेरी गुड मॉर्निंग एंड अस्सलाम वालेकुम। ओके, बिस्मिल्लाहिर्रहमानिर्रहीम। मेरा टॉपिक आज काफ़ी बड़ा है और वही कह रहे हैं 1 साल का लेक्चर है, लेकिन I'll try to concise it. आधे घंटे की presentation को हमने 20 मिनट में देना है, तो it's a race against time. And if wherever 20 minutes are, I'll stop my presentation. Okay. This is my disclosure statement. There is no commercial इसके साथ मेरे कोई lecture के. Okay, orthodontic management. Today I'll be presenting the orthodontist's role in alveolar molding and its long-term effect. तो long-term effect का मतलब ये है कि उसने बच्चा नहीं रहना, उसने adult भी हो जाना है. आज what I'll present is an overview of orthodontic treatment, possibilities, limitation and difficulties with treating patients with cleft lip and palate. We know that cleft palate patients have many problems, जो सारी यहाँ पे दी हुई हैं, feeding, hearing, speech, disruption of facial growth. Anything which we can do to reduce the severity would be, I think, a game changer. So what I'll be discussing is how we can play our role in reducing that facial deformity. Today, the whole presentation will be divided into 4 parts. The first part, I will go for nasal-alveolar molding. Nasal-alveolar molding is done from day 1. The child comes to me when he is 1 day old, and till 3 months, because we all know that we are waiting till 3 months before the plastic surgeon will do the lip surgery. So that is the time which we use the alveolar molding period. So my first scheme will be the case presentation, how we do nasal-alveolar molding, how we do in a unilateral, how do we in bilateral. Second part would be when the child will be about from 7 to 9 years, क्योंकि जो cleft का बच्चा है उसकी तो पूरी life चलनी है ना, तो how we will go about it. इस तरह you will have a complete picture, but a short picture, inshallah. Third part would be I will show you two cases who didn't have any alveolar molding and how we treated them. And the last I will do a little bit, only maybe one case of how we can treat the facial, we can improve the facial profile by just removing lower 2 bicuspids. Let me start with the first part, which is nasal-alveolar molding. Nasal-alveolar molding. We know that as I have discussed before and I've shown you a picture of a patient, that the orofacial cleft is one of the most common congenital deformity of the face which we see. And in the world, I think the data is about 1 into 7 in 1,000 live births, and in Pakistan, we have one of the highest rate of infants born with cleft lip and palate. So the main idea is the treatment of choice is surgery. We are not surgeons, plastic surgeons will be doing the surgery. What our aim is, कि जो cleft segments which are displaced, we concise them in a way that when the plastic surgeon performs the surgery, the result should be not disfiguring. In fact, it should be in a way that child should not face disfigurement in their life. So this is done in a day 1. From birth to 12 weeks. We know that those who know about the cleft palate patients, that we don't do the surgery at birth when a child is born. You do the surgery when the child is 10 grams of hemoglobin, 10 weeks of age, and weight is 10 pounds. So they are already waiting. That is the time where orthodontist does the molding part. Impression, you do use the elastomeric material, put the child upside down. It's better to have taken it in this position. In this way, the mold which we are taking doesn't get stuck. All the liquids are displaced, and when you take the impression, the child cries. So when the child cries, it means the airway is open. Different materials which are used for nasal-alveolar molding, mestistol, steri-stips. These are all used to attach the plate, which you can see on the lower, your left side, to the patient's mouth. So we use all these attachments to attach it and start the molding. Molding is done in such a way that you start bringing the two, it's like a negative sculpturing. आप प्लेट को वहाँ से ग्राइंड करते जाएंगे जहाँ पे आपने मूव करना है, और जिस तरफ से मूव करना है वहाँ डिपॉजिट करते जाएंगे. In this way, in the end, the alveolar cleft is reduced to 0. And I start the nasal stent when a child has this gap is reduced less than 5 millimeter. Okay, let me start with the first case. I will call him baby J. He came to me when he was 1 day old. Our main aim is to align the alveolar ridges, bring the nasal tip in the center, bring the nose in such a position that when the child is ready for the surgery, the surgeon doesn't have to pull the two lateral segments together to stitch, because the more force you use it, the more pressure will be on the growth and the child will develop the midfacial deficiency. So, if you try and do surgery in this patient, obviously you will get that stress on the scar which might open up after surgery and the patient will have disfigurement, or you might have the case in which you will have a midfacial deficiency. If you can see the columella, which is the middle part of the lip, usually it's about 3 to 4 millimeter, is totally missing in these children. So with our tegaderm and steri-strips, we stretch it in a way that it becomes as wide as 7 millimeters. So the plastic surgeon has enough to work on. This is the tray in patient mouth. As soon as you put the patient's tray in the mouth, you wait, you see if the patient is not gagging, and then you tell the mother, why don't you feed him or her, so that the child is comfortable, the mother is comfortable. The first day when we put the plate, we tell them to wait in our office for at least half an hour, till they're comfortable. So every week the children come to my clinic, and from here we go till there in about 8 weeks. If you can see, to do surgery for a surgeon is so much easier. The alveolar ridges are touching each other, the lip has increased, the columella is increased, and the nasal formation with the nasal stent has made the nose in such a way that the nasal tip deviation or deformity is taken care of. So I have seen, what we use, जैसे हमारे यहाँ कहते हैं ना चिल्ले के बच्चे का नाक बिठाते हैं और माथा बिठाते हैं, इसी तरह that is the quality. We have a high level of hyaluronic acid in the body, and that is the plasticity which we use to mold the child cleft area. Immediately after surgery, if you can see with the molding, we can have a nice cupid bow, and the child, this is the happy moment. That is the time when a child would have a face and a growth without any pressure or stretching on the scar and would grow normally. The same child at 7 years of age. Of course, we would have the dental problems, where the cleft is, maybe lateral is missing, there will be crossbite, but that can be taken out where the second part of my lecture will start. Another case from the day 1. This is the patient before nasal stent. After the surgery, at 3 months, 6 months, 3 years, and 7 years. This is a very small talk, and now it's already concise. So I don't have time to show too many cases, but 90% of the patients usually end up with a nice profile if they have a molding. So the treatment of the surgery outcome is so much better if a nasoalveolar molding is done. Just to show a bilateral case, quick, bilateral would have more problem because the cleft is on both sides. So premaxilla is rotated. What we need to do is we need to push that premaxilla between the two lateral segments. What they used to do, they used to cut the premaxilla and would do the repair. Otherwise, when they push the premaxilla and do the repair, mostly the stitches open up and the patient has more disfigurement. So this is the, with the bilateral, usually I take 2 nasal stands, or unilateral, I make 1 nasal stand, and sometimes when I need to move more and I have less time, then I even put 2 nasal stand in a unilateral. This is patient before surgery. Now if you can see, the premaxilla has shifted nicely between the 2 lateral segments, and this is the time when you can send to the patient to the surgeon. That is immediately after surgery, him at 7 years of age. Of course, the bilateral are more difficult than the unilateral, but now I think what happens is that then the orthodontist has to do the molding before they do the surgery. This is the patient we did with the molding plate, but nasal stents was not used because parent didn't want to, because जब भी आप nasal stent use करेंगे, you will have, the patient will cry. So mom didn't use it, so I just kept that slide there. I have few videos which shows how we have put the nasal stent, and the child usually get used to the and then we have, if you have used the nasal stent properly, the child really has a nice nose, no pressure on the scars, and the growth is so much better. This is one of the paper which I had done with my resident, and it shows that there is a columellar length increased and improved nasal tip projection in unilateral and bilateral cleft lip and palate patients. Okay, I go to the second part. जी कितना time रह गया? हाँ? खत्म हो गया? अच्छा. The second part of my अगर आप उसको ही रहने दें, बार-बार move ना करें. Okay. Interceptive part, in which we do maxillary expansion, we do face mask therapy and preparation for all alveolar bone grafting. As I told you, the cleft patients, when they grow and they come to this part of the life, that is the time when we start with these 3 therapies, whichever is required. Maxillary expansion, which corrects the crossbite, reduces the facial deformity, and creates space for bone grafting. You know, where the cleft was, that bone is still missing. But that is not correct. That bone is not grafted at the time when the child is young or maybe less than a year, because that really causes the midfacial deficiency. So it has to be grafted at this time. One case which I am presenting, she had both anterior and posterior crossbite. As you can see, the profile is also deficient. Midfacial deficiency nazar aa rahi hai. When you look at the intraoral picture, you would see the expander there, which we are trying to, for the horizontal discrepancy or crossbite or posterior crossbite, we are using the expander, and for the anterior crossbite, we will have reverse pull headgear. So after, what I do is I do expansion and then usko constriction, then expansion, then constriction. That really loosen up the circumaxillary sutures. After we have done enough expansion, we add the reverse pull headgear. So with reverse pull headgear, I get a very good responses. So it's a good orthopedic tool if a patient wears it. And for me, that if I can do enough counseling and patient agrees to wear it, which is only you have to wear only at night, then you avoid the orthognathic surgery, which has to be done at 18 years if you don't have midfacial growth. So midfacial growth, even with nasal velar molding, would be slightly restricted. If you have a reversible headgear, it will let the face grow. The maxilla at the pace, mandible is growing with a natural pace, and maxilla will grow with an assisted pace. These are the X-rays of the same patient. And after her orthodontics is complete. As you can see that ANB -3 to 0 was attained, and a patient had good profile. If you can see the lower lip which is projecting downward, in this patient also I did later on 2 lower bicuspid extractions. One of my publication regarding reversible headgear, it was in Asia Pacific Orthodontic Society journal. Sometimes as an oral surgeon or when you send the patient after expansion, you would see the teeth lying right in the middle of the cleft area. This patient would refer to me that somebody has sent him after expansion. Okay, expansion is done, but what about these 2 incisors? How do we get, because if an oral surgeon has to put the bone graft, they need the space to put the bone graft. For that, you simply put the full strap up of orthodontic brackets and start pulling the teeth in a way that the arch is complete and there's enough place for bone grafting. First is when the patient was referred, 6 months when we had prepared it for bone grafting, and usually after bone grafting for 6 months I don't touch the patient. And after 6 months I would do the full strap up and start the orthodontic. And of course, as soon as the incisors are in a correct position, the lip also follows and the profile improves. Okay. The third part of my talk is about the patients who were not treated with nasal velar molding and had severe deformity, because when they tried to push the bilateral cleft patient premaxilla in for the closure of lip, usually either it descends down or it descends in the nose.
3 minutes.
Oh, मैं तो इतना तेज चल रही थी. Okay. First patient, as you can see, the premaxilla is right down, covering the whole incisors. When a child smiles, the whole premaxilla is down. Now the plastic surgeon cannot, or an oral surgeon cannot cut the premaxilla and push it in, because it will lose the vitality and will eventually lose. So we decided to put orthodontic implant and start pulling the premaxilla up. These are sequential pictures. Just wanted to show in CBCT the root was okay. Only with orthodontic, without any surgical intervention, we were able to bring the incisors to a respectable, decent position. As you can see in the CBCT, the roots are not disturbed and there is no root resorption. This is the same patient. Second patient. Again, a 9-year-old patient, again came with the same problem with premaxilla descended down. We decided to do orthodontic implants in competent lips. The main idea was to expand the maxilla and push the premaxilla in the middle for the oral surgeon to do the bone grafting. We started with orthodontic implant. The whole segment started going up. 8 months. This is the radiograph. This is her. And this was enough for the oral surgeon to do the bone grafting. This is her after 1 year, 1.3. This is her before and after. The last part. This is the same patient when I decided to start with the orthodontic. As you can see, the upper and the lower incisor are bimaxillary protrusive. We decided to extract in the lower and not to extract in the upper because we already had spaces. The same patient. This is the arch. So we have the lower spaces closed. This is the lateral SAF. This is the CBCT. Same patient. After the lower incisor extraction, we could improve the profile. Rest of the things will be done by plastic surgeon. This is her before and after, and the story is still on. Thank you so much. Key takeaway, take-home message, the nasoalveolar molding will bypass lot of surgery and they will be able to obtain better results. Early treatment with maxillary deficiency using appliances like protection face mask can be used to maximize the growth potential of nasomaxillary complex. Lower extraction always helped me to bring that lower lip in and give a better profile. And temporary anchorage devices has opened a new vista. Thank you, everyone.
Thank you.
Please लगा दो. मैं जाऊँगी, complete तो करने दो. Okay, we have an international medical education conference in College of Physician Surgeon, which is with the Royal College of Africa together. And it's going to be on 13 to 14 January. I would like to invite all of you. And we have a Pakistan Association of Orthodontics international conference coming from 19 to 20 December in Karachi. Again, I invite all of you. Thank you so much. Now I'm done. Thank you.
नहीं Yes, sir. Thank you so much, ma'am. To deliver today's next lecture on revelations of Karachi and Hyderabad cancer registries, I would like to invite Professor Shahid Parvez. He is professor and consultant histopathologist, Department of Pathology and Laboratory Medicine, Aga Khan University Hospital, Karachi. Chairperson of Karachi Cancer Registries and co-chair of National Cancer Registry.
All right, thank you very much, organizers, in particular Dr. Sana Mirza of Oral Pathology, LUMHS, Professor Ikramuddin, VC, and dear colleagues. I am a pathologist, histopathologist at Aga Khan University Hospital. Now, this is my 32nd year, so working for over 3 decades there. And obviously, we receive the largest number of biopsies within Pakistan, something like this year, we will be receiving about 100,000 biopsies, including all organ systems. So cancer registries are very important because cancer is not one disease. And although strictly speaking, cancer is due to DNA damage or some epigenetic factors, the lifestyle or what you call environment plays a huge role, that what we eat, where we live, we smoke or not, we drink or not, we chew or not, and everything, So purpose of and importance of cancer registries include to collect the cancer incidence data to provide essential information to healthcare providers, government, researchers to identify major risk factors in a population based on their lifestyle, because some cancers are preventable while others are not preventable. So cancer registries are the foremost requirement for cancer control program in any country, like prevention and screening. So this also helped the government and policymakers to prioritize government policies and fund allocation and ultimately reduce the burden of cancer. So Karachi Cancer Registry was revived after a gap of 10 years. Actually, the first ever cancer registry was initiated by late Professor Yasmin Burguri, a professor of pathology, in 1995. And I was also all along involved with her. She was also part-time faculty at Aga Khan University Hospital. And till 2005 and 6, that the Karachi South Cancer Registry was the only data available from Pakistan, which was used by the IRWHO to extrapolate the cancer incidence and patterns in Pakistan. But unfortunately, one day she didn't get up. And like what happens, everything fell apart with her. And then it took us about 10 years to revive the Karachi Cancer Registry, right? So we revived it in 2017 and started collecting data, on voluntary basis, because cancer is still not a reporting disease like in most developed countries, like with dengue fever or COVID fever. Otherwise, the data will be much more robust. So this is our jungle, urban jungle, Karachi, Pakistan, is the fifth most populous country in the world. 225 million of us, as per yesterday, I think on 16th or 17th of November, the planet Earth touched 8 billion mark, and we are the fifth most populous country, and Karachi is in the top 10 most populous countries of the world, right? So having such a big population, diverse population with diverse habits, having no cancer registry, a big pity. However, we were fortunately able to revive it from 2017 on voluntary basis, and these are the participating centers, from Karachi. And this was the first 3 years data which we published. And now for this session, only yesterday I got the fully compiled data from our statistician, which is based at PHRC, which is now NIH, at Jinnah Postgraduate Campus, JPMC campus, of the 5-year, 2017 to 2021. So I will be sharing with you the 5-year data of the Karachi Cancer Registry. So total 65,886 cases were entered in the database, and there were more females than males. And why this? Because breast cancer is so common, right? So that makes, more cancer prevalence in females than males, right? So this is the age standardized incidence rate of commonest tumors in adult females, that is more than 20 years, for the last 5 years, and you can see that breast is going through the roof. Unfortunately, breast cancer in Pakistan is one of the highest in Asia. If you exclude the Ashkenazi Jews, the European origin Jews, Einstein was an Ashkenazi Jew. We have one of the highest incidence, unfortunately. And in the textbooks, you read that nulliparity is a risk factor. But here, yesterday, the report which came in the dawn, still the per fertility rate is 3.6 per woman, So multiparity is also a risk factor. And then you can see that second most common cancers in females of Karachi is the oral cancer, right? And I won't go, for sake of time, to the rest of the cancers, right? And this is male. Oral cavity cancer is the most common cancer. When I said, I joined AKU way back in 1991. And at that time, the most common cancers in males used to be the lung cancer, right? Now, the lung cancer has gone down because the lifestyle has changed, and we have seen that the chewing habits has replaced smoking in a big way. What are the reasons? Probably still more socially acceptable. The other day I was coming from Islamabad and the guy sitting next to me was comfortably chewing, but you can't smoke in the, in the aeroplane. So several things. And so now oral cavity cancer for the last, over a decade is the #1 cancer, and you can see that the lung cancer has dwarfed in front of the oral cancer. And these are the children, and in children, the worldwide, most of these are non-preventable cancers, and most common are the leukemias, bone tumors, soft tissue tumors, brain tumors like medulloblastoma. Okay, and this is what WHO or IARC use. Every 4 years, they use the robust data from each country and put it on their website. So this is Pakistan, and you can see that if you combine both sexes, breast is the most common. However, in males, oral cancer is the most common cancer, while in females, excluding breast, is the second most common cancer, right? And mind you that this is a preventable cancer. 80% in our archive were chewers. One of the PhD student, Namra, at AKU, who worked on the carcinogenic pathways and HPV association on oral cancer, she was struggling to find patients, to recruit patients of oral cancers who were not chewers, right? 80% chewers. So it means that 80% cases are preventable. There are some cancers which are not preventable. Even breast cancer, there are some risk factors, but you can't prevent it. So, the screening and mammogram and all that. Brain tumors, they come out of blue. That's the biological bad luck. But most lung cancers, oral cancers, liver cancers, hepatitis B, C, these are preventable cancers. Cervical cancer, HPV. And then, I don't think Professor Ikram Ujjan is here. I am also happen to be a counselor of College of Physicians and Surgeons, Pakistan, and like my colleague, Dr. Ambreen, who's here, for the first time a pathologist came in the council. And I also oversee the Department of Pathology of the College of Physicians and Surgeons. So I think about a couple of years ago, or 1.5 years ago, I came to visit the histopathology section for accreditation. And I was pleasantly surprised to see that such a major turnaround on the footsteps of what has been done by the DAO, University of Health Sciences. Some highly good qualified, I think I found 2 or 3 which were trained at Aga Khan University, good infrastructure with immunohistochemistry, and very cheap, about on what we charge at Aga Khan, maybe 7,000, 8,000. In 1,000, a good quality report, good workup. So now they have approved CPSP residency program in histopathology as well. So this is diagnostics is the basis of the modern medicine. At least 70 to 75% clinical decisions are based on laboratory diagnostics. In cancer, it's 100%. So even Aga Khan, I think the success of Aga Khan was because the diagnostics were reliable, right? So that is something which I would like to congratulate. And then at the same time, we asked Professor Ikram and other pathologists that you have the collection points all over interior Sindh, Larkana, Nawab Shah, and they get good volumes. So why not, you join us and send us the data, and we call it Hyderabad Cancer Registry. So Hyderabad Cancer Registry, we started collecting data for the last 2 years, and this is very quickly, I will show you a couple of figures of the Hyderabad Cancer Registry. And you see that if you combine both male and females, again, obviously the breast cancer is the most common cancer. And you see number 2 and number 3, the ovary and uterine and oral cavity, very little difference. So you may still call it the second most common cancer, because this is a small data, 2 years data. So maybe when we have 5 years data, the picture will be more cleaner than this. And this is the, so we, unfortunately, a preventable cancer we see at a very advanced stage. You see, going through and through, ulcerating outside, mutilating surgery, whole tongues chopped off, whole, jaw chopped off. It's a nightmare, the quality of life after having this. And you see this lady, why this neck is bulky? Metastasis, So like any other cancer, they present very late. So major culprits in Pakistan, as you know, that the gutka is something very elusive, It's a mixture of sun-dried, so that is the naswar. I will come to beetle, the gutka. What is gutka, So you see, gutka is highly addictive, and it's a very dubious product, largely smuggled from India, but also in Pakistan, in Karachi, in Lalukhet and other places. Lots of factories are producing, and God knows what is inside, But it's very, very effective, and it's disposable. They keep it in pocket, whether in the aeroplane or anywhere, they can easily. So gutka is the most elusive thing which has changed the paradigm, Otherwise, in the Indo-Pakistan, the culture of having the areca nut, a little bit areca nut or pan chalia was not uncommon, but we never saw such an explosion of the oral cancer. That happened mainly because of this, what you call gutka and mawa and things like that. So highly carcinogenic and addictive. And I think that I kept second part, but I won't go. I will stop here. I knew that there will be some problems. So I had 2 parts. So basically this was the, we studied the high-risk human papilloma virus, because you know that oropharyngeal cancer have a strong association like cervix in about 10 to 15% of the cases with high-risk HPV, but not in oral cancer. So a very low prevalence of the high-risk HPV. So I will stop here for sake of time, and thank you very much for your attention. Yeah.
Thank you so much, sir. Thanks a lot, our respected panelists.
शुरू करें
Ladies and gentlemen, कहाँ है चीफ गेस्ट किधर है?
चीफ गेस्ट अंदर ही ना तने शुरू करना तुम इनॉग्रेशन शुरू करो नहीं चीफ गेस्ट पहली लाइन
मैं
चीफ
माशा
गेस्ट
बोला ना।
सर रिजवान ने कहा ना
नहीं
पहला चीफ गेस्ट का है ये लैपटॉप ले लें
आप यहाँ पे करो और उनको बोलो यहाँ बोलो।
क्या Ladies and gentlemen, let us welcome our worthy chief guest who has arrived at the moment. सही है
नीचे वो रखवा देते किसको बोलो नीचे ये रखते हैं यहाँ पे
उसका नाम अब्दुल समी है
today with the presence of Professor Naushad Ahmad Sheikh, President of Pakistan Medical Commission Islamabad and former Vice Chancellor, Liaquat University of Medical and Health Sciences Jamshoro. Professor Muhammad Farooq, Vice Chancellor, Veterinary University Sakrand. Chief Patron and Vice Chancellor, Liaquat University of Medical and Health Sciences, Professor Ikramuddin Ujjan, who has very graciously consented to our invitation in spite of their busy schedule and multifarious preoccupations. Sir, we are honored to have you with us today, and you have been an indomitable spirit to maintain the discipline. हर चीज अच्छी लगी, हर शख्स अच्छा लगा, हर चीज अच्छी लगी, हर शख्स अच्छा लगा, आप आए महफिल में तो शहर भर अच्छा लगा.
Lastly, my warm words of welcome goes to the all invitees, vibrant undergraduate and postgraduate students, and distinguished audience from all over the country. I thank you all for coming and making this moment worthy. Let us officially inaugurate this splendid occasion.
My name is Rabil Kadir from final year BDS.
And I am Zainul Abdeen from second year BDS.
Starting with the glorious name of Almighty Allah, who is most beneficent and merciful. It is indeed beauty of our religion to invoke Almighty Allah at the beginning of every event.
And when the Quran is being recited, then listen to it and remain silent, so that perhaps mercy may be shown to you.
तेरी कुदरतों का शुमार क्या, तेरी वसअतों का हिसाब क्या, तेरी कुदरतों का शुमार क्या, तेरी वसअतों का हिसाब क्या, तू मुहीत आलमे रंग गबू, तेरी शान जल्ला जलालहू. So, I would like to call Mr. Asad Sheikh for recitation of Holy Quran.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. ولله جنود السماوات والأرض وكان الله عزيزا حكيما. إنا أرسلناك شاهدا إنا أرسلناك شاهدا ومبشرا ونذيرا لتؤمنوا بالله ورسوله وتعذروه وتوقروه لتؤمنوا بالله ورسوله وتعذروه وتوقروه وتسبحوه بكرة وأصيلا صدق الله العظيم.
जज़ाकल्लाहु खैर। बस ये बात हवाओं को बताए रखना, बस ये बात हवाओं को बताए रखना, रोशनी होगी चिरागों को जलाए रखना। लहू देकर जिसकी हिफाजत की शहीदों ने, लहू देकर जिसकी हिफाजत की शहीदों ने, इस अर्ज़ पाक को दिल में बसाए रखना।
Let us pay tribute to our country. So, ladies and gentlemen, I would request you all, please rise in the respect of national anthem.
Thank you, everyone.
Professor Nasra Haider Kasi, pioneer of Anatomy Department, LUMHS JAMSHORO, is sadly no more with us. So I will request everyone to please pay tribute of 1 minute silence to the departed soul.
Thank you, everyone. We are honored to have been given this opportunity to pay tribute to the glorious past of this institution, and we are immensely delighted to share it with everyone.
Institute of Dentistry, Liaquat University of Medical and Health Sciences was established in 1963. It is Pakistan's second oldest dental college and first dental college of Sindh and Balochistan. Initially, it was located at MICS LUMHS. Dr. Syed Malik and Dr. Isa Arai are the two main leaders who came forward and took the step for the establishment of this institute. Professor Isa Arai has given 30 years of his life for establishment and betterment of this institute. After Professor Isa Rai in 1996, Dr. Rafiq Memon took the responsibility of this institute till 2010. And now, as we all know, our worthy Dean, Professor Dr. Feroz Ali Kalhoro, is a leading person of this institute, and he has been such a driving force for this project for many years. Thank you, sir.
The land of Sindh is sprinkled with spiritual power through its saints. It focuses on its academic excellence to provide quality dentistry care to the community and the country with and College of Physicians and Surgeons Pakistan CPSP. After that, CPSP also gave full accreditation for FSPS2 training. In April 2012, a certificate of registration was issued by Moody International as a quality management system of all specialities, as the university was found compliant with ISO 9001-2008. Received the International European Quality Award in Education Sphere on 3rd July 2017. This award recognizes the high level of the provided learning process, state-of-art facility, advanced dental care. Established in August 2017, Dental OPD provided quality dental treatment to public on highly subsidized rates, equipped with ultra-modern equipment, CBCT and 3D digital radiographic, CSSD for cross-inflection control. Faculty of Jamshoro, Advanced Dental Care Center, Hyderabad, and Old Dental OPD, LUH, Hyderabad, have 5 clinical departments serving as OPD.
Gratitude, respect, pride, and honor. This is how we feel as Institute of Dentistry, Liaquat University of Medical Health Science, organizing International Dental Conference. I am more than conscious at the moment the importance of this international conference. Now, I would humbly request to the Professor Dr. Feroz Ali Kalhoro, Dean, Faculty of Dentistry, and Patron 5th International Dental Conference, to escort the Chief Guest, Professor Naushad Ahmad Sheikh, President, Pakistan Medical Commission, and former Vice Chancellor of Liaquat University of Medical Health Science, Jamshoro. Professor Muhammad Farooq, Vice Chancellor of Veterinary University, Sakran, and Chief Patron and Vice Chancellor of Liaquat University of Medical Health Science, Professor Dr. Ikramuddin Ujjan, to please come upon the stage and be seated.
I would also request our special guest, Professor Dr. Nazia Yazdani, founder member of Pakistan Prosthodontics Association. Please, ma'am, come on stage and take your respective seat.
I would also request our special guest of today's event, Professor Dr. Ambreen Afzal, Dean, Faculty of Dentistry, College of Physicians and Surgeons, Pakistan, to come on stage and take her respective seat.
I bid a hearty welcome to Dr. Maqsood Ahmad Sumro, Patron of Pakistan Prosthodontics Association, Associate Professor and in charge of Prosthodontic Department.
I bid a hearty welcome to Professor Riaz Ahmad Waraich, Professor and Head of Oral and Maxillofacial Surgery, University of Lahore, and President, Pakistan Association of Oral and Maxillofacial Surgery. Sir, please come upon stage and take your respective seat.
I bid a hearty welcome to Professor Dr. Amir Mahmood Bhatt, Chairman of Organizing Committee Dental Conference, our guide, teacher and mentor. Sir, please come on stage and take your seat.
Ladies and gentlemen, to commend this auspicious occasion, I would request our Honorable Professor Dr. Amir Mahmood Bhatt to kindly come and deliver the welcome address.
Bismillahirrahmanirrahim. Excellency Professor Nushad Ahmed Sheikh, President of Pakistan Medical Commission, our worthy Vice Chancellor Professor Ikramuddin Ujjan, respected Vice Chancellor, Second University of Veterinary Sciences, Professor Farooq, Dean in Dentistry and the patron of the conference, Professor Feroz Kaloro, special guest of the afternoon, Professor Nazia Yazdani, Professor Amreen Afzal, Professor Riyad Ahmed Wadaij, and the patron of the Pakistan Prosthodontic Association, Dr. Maqsood Sumro, invitees, respected teachers, my guests, my students, Assalamu alaikum. It's a real pleasure for me to welcome you all on this 9th Pakistan Prosthodontic Association Conference and 5th Liaquat University of Medical Health Sciences Conference for Dentistry. We have the theme of this conference that exploring and redefining the future of dentistry. For that, we try to establish a platform where we have invited more than 30 national and international speakers, and we have arranged more than 11 workshops with the local and international facilitators. The objective behind was that we try to give an opportunity to the audience about the recent advancement in the dentistry. We know that we have a three folds of dentistry. One is the materials. We need emergency protocols as well. We need skills as well. We need the development in this sectors as well. So after a long pause of 2.5 years, because of the pandemic, we got the opportunity to interact with the people. And inshallah, this conference will give you the opportunity to meet with the colleagues, seniors, and the eminent professors of this university who have achieved the excellence in this field. I want to extend my greetings to the traders and the medicine companies who joins their hands with our hand to make this show more graceful. I am especially thankful to my Vice Chancellor, Professor Ikramuddin Ujjan, and the Dean of Dentistry, Professor Feroz Ali Kaloro. Without their support, it was not possible to arrange such a big show. And in the last, I am thankful to my team who worked very hard day and night to arrange such a big show. I hope you will enjoy and learn from this conference. Thank you. Allah Hafiz.
Thank you so much, sir. I would like to request Dean Faculty of Dentistry, Professor Dr. Feroz Ali Kalhoro, to kindly come and deliver his address.
Thank you. Chief guest of the event, Professor Nushad Sheikh Saab, President, Pakistan Medical Commission, Honorable Vice Chancellor of LUMHS, Professor Ikramuddin Ujjan Saab, Vice Chancellor, University of Veterinary Sciences, Sakran, Professor Mohammad Farooq Saab, Professor Nazia Yazdani, renowned personality in dental fraternity, Professor Riaz Wadaj Sahab, Professor Ambreen Afzal, the Dean Faculty of Dentistry CPSP and Dental Counselor of CPSP, and Professor Maqsood Sumro Sahab, Professor Riaz Wadaj Sahab, Professor Amir Bhatt Sahab, and speakers, delegates, students, Assalamu alaikum. And I welcome all of you and thanks all of you for participation in this 5th LUMHS annual dental conference and I think 9th conference of the Pakistan Prosthodontic Association. And a special thanks to the speakers and delegates, guests who have come from different cities of the Pakistan, from Peshawar, from Lahore, from Islamabad, from Karachi, from Larkana, from Mirpur Khas. So thanks all of you. And a special thanks to the speakers who have come from different countries as well. The speaker from the Palestine, speaker from the Qatar, from the Saudi Arabia, from Malaysia. So thank you, all of you, because of your presence here. इसको जैसे उर्दू में कहते हैं कि चांद लग जाते हैं तो that is actually this is all. Actually we are annually organizing the dental conferences, but unfortunately last couple of years जो है because of this COVID वो हम नहीं कर सके, हम नहीं किया बल्कि पूरी दुनिया में दिस वाज द प्रॉब्लम ऑफ कोविड. तो जो ये फिज़िकल गैदरिंग थी वो नहीं हो पा रही थी और कोविड में हमें ऐसे लग रहा था कि शायद कभी हो भी नहीं पाएगी शायद. तो दुनिया जो है वो ऑनलाइन वर्चुअल एंड ऑल दैट वी हो गई. नो डाउट द इंफॉर्मेशन एंड ऑल दैट कैन बी शेयर विद दीज गैजेट, दीज टेक्नोलॉजी. मगर जो बात इसमें फ़िज़िकल गैदरिंग एंड फेस टू फेस गैदरिंग में है so that is not actually what they call it a virtual reality, but it's not actually a reality. Reality is this. So this gathering, this conferences give the platform for sharing the knowledge, thoughts, for networking and all these things. So this is so important, and hopefully we will continue this trend of arranging such event annual basis. So I am thankful and appreciating our team under the leadership of Professor Amir Bhatt. They did a wonderful job and to organizing such a the gathering. And क्योंकि कोविड में जैसे मैंने कहा कि बड़ा हम हो गए थे ऑनलाइन और ये वो, तो फिजिकल गैदरिंग आफ्टर कोविड ये हमारी पहली है और मेरे ख्याल में दे यू नीड सम एप्रिसिएशन एंड देयर टीम. And especially Dr. Irfan Sheikh Saab, he did also a very good job. So all are appreciating efforts as well. And especially Professor Naushad Saab is here. So first of all, congratulations to become the President of Pakistan Medical Commission. And thank you so much for accepting our invitation and giving us time for this. And sir has been remained much kind, especially to dentistry during his tenure as a Vice Chancellor of the LUMHS from 2007 to 2017. और बहुत कुछ डेंटिस्ट्री को सर ने दिया. तो two things are so important, अभी आपने वीडियो में भी देखी होंगी. One thing is the dental skill lab. It was established in 2014, और 2014 में this kind of the skill lab है. It was one of the best skill lab in Pakistan, and still it is in terms of the equipment, or in terms of the technology, or in terms of the design and all that. It's a very unique and very important. और यही अभी हम इसको यूटिलाइज कर रहे हैं फॉर these type of events जो हमारे आ रहे हैं facilitators, for speakers. They are enjoying, they are appreciating the such kind of wonderful conducive environment जहाँ हम ये academic or all these activity can be performed. So in better and effective way. So ये जो gift है ये नौशाद साहब की मेहरबानी थी और वो सर ने हमें ये डेंटल स्किल लैब बना के दी थी। जो दूसरा जो था अभी आप देख रहे थे कि एडवांस डेंटल केयर सेंटर जो न्यू डेंटल ओपीडी है विच इज़ नाउ फुल्ली इस्टेब्लिश्ड एंड फुल्ली वर्किंग इन फंक्शनल स्टेट, तो वो भी सर की मेहरबानी है। और इन 2016 आई नो दैट, तो उस वक्त थे मरहूम जावेद साहब प्रोजेक्ट डायरेक्टर थे, तो सर ने उसको कहा कि यू हैव अ 6 month, I need this, you know, building and all that fully furnished within a 6 month. तो एग्जैक्टली 6 महीने में वो बन भी गई थी और सर ने मुझे बुला के कहा कि अब बन गई, अब जाके चलाओ, और अगर नहीं चली तो अगले महीने की तनख्वाह नहीं मिलेगी आपको। तो मैंने कहा सर मेरी साइंस से तो पूरी यूनिवर्सिटी को तनख्वाह मिलती है, तो सर एज ए गिवन साइनिंग अथॉरिटी टू मी, और वो अभी तक मेरे पास है। तो थैंक यू सो मच। सर के साथ बहुत वंडरफुल टाइम गुजरा और हमेशा हमारे एक नज़र करम रही डेंटिस्ट्री पे सर की। तो उस वक्त आई रिमेंबर, और सर को भी याद होगा कि जब वो डेंटल ओपीडी हम बना रहे थे तो उस वक्त सर ने कहा कि जो नेक्स्ट होगा वो हम इसको डेंटल कॉलेज बनाएंगे, विल इस्टेब्लिश एज अ सेकेंड डेंटल कॉलेज ऑफ लम्स। बहरहाल जैसे मैंने कहा कि आफ्टर दैट ड्यू टू द कोविड एंड ऑल दैट वो थोड़ा डिले हो गया, मगर अब इकराम साहब आ गए हैं और उसने भी हमसे 2 वादे किए हैं और होपफुली वो वादे निभाएंगे। एक तो ये शुरू सर ने खुद ही कहा था मुझे कि यार योर इंस्टीट्यूट सो ओल्डेस्ट इंस्टीट्यूट ऑफ द पाकिस्तान और यू आर इन अ हॉस्टल उसके बिल्डिंग में है, तो दिस इज़ एक्चुअली सम हाउ इनजस्टिस टू यू। तो उसको हम अभी न्यू बिल्डिंग जो है वो इंशाल्लाह होपफुली अंडर प्रोसेस को वो उसने इकराम साहब ने हमसे प्रॉमिस किया है कि होपफुली एज सुन एज पॉसिबल कि वो आपको एक पर्पस बेस्ड बिल्डिंग हमें बना के दे देंगे। एंड आई थिंक वी डिज़र्व दैट कि एक फुली पर्पस बेस्ड बिल्डिंग फॉर डेंटिस्ट्री होनी चाहिए, फॉर क्लिनिकल, फॉर एकेडमिक एंड ऑल दैट। और जो सेकेंड जो वो वही हुआ था कि इन दैट आफ्टर दैट डेंटल कॉलेज फॉर सेकेंड डेंटल कॉलेज होपफुली हम इस्टेब्लिश करेंगे। और उसमें जैसे अभी मैंने कहा बीइंग अ प्रेसिडेंट ऑफ रेगुलेटिंग बॉडी पाकिस्तान मेडिकल कमीशन, वी होप कि जो नौशाद साहब की सपोर्ट अगेन एंड हेल्प विल रिमेन विद अस for establishing a new dental college as well. So thank you so much. Have a wonderful this evening.
Thank you so much, sir. Now I would like to request the worthy Vice Chancellor of LUMHS, Professor Dr. Ikramuddin Ujjan, to kindly come and deliver his address.
Bismillah ar-Rahman ar-Rahim. Honorable President, Pakistan Medical Commission, Professor Naushad Aman Sheikh Saab, Dean Dentistry, Professor Feroz Ali Kalodo, Dean Dentistry, College of Physicians and Surgeons, Professor Amreen Absal, Patron and Founder Member, Pakistan Prosthodontic Association, Professor Nazia Yazdani, Professor Riaz Wadaich, Professor Amin Mahmood Bhatt, Chairman Organizing Committee, Dr. Maqsood, Professor Anila Ata Rahman, ex-Vice Chancellor Shaheed Mohtarma Benazir Bhutto University, Professor Shahid Parvez, President Pakistan Association of Pathologists, respected deans, directors, chairpersons, dear faculty members, distinguished guests, representatives from electronic and print media, ladies and gentlemen, assalamu alaikum to everyone and good noon. It is my proud privilege and honor to welcome you all on this auspicious occasion of 5th International Dental Conference at Liaquat University of Medical and Health Sciences, Jamshoro. I am extremely thankful to President Pakistan Medical Commission and our ex-Vice Chancellor, Honorable Professor Naushad Aman Sheikh, for having accepted our invitation to grace the occasion as chief guest of this conference. This conference aims to bring together the dental experts, researchers, research scholars, potential scientists, professors, students from all over the world in sharing the recent advances of treatment, techniques, and new research in dental sciences. Presence of other esteemed scholars from all over the country and abroad in this conference reflect their priority of sharing their knowledge and new techniques with juniors and senior faculty members in the field of dentistry. An international conference of dentistry provides excellent platform for teaching, learning, sharing the network of our dentists, which covers all the important aspects of the dentistry. In this age of modern medical and dental sciences, there is dearth of understanding for linkage between education and research. This conference facilitated in one of the prime functions of the new emerging technologies, that is to gauge what are the challenges in the process of benefiting human being. It is also assist to explain how positively we could transform the mindset of our peoples and bring up qualitative change in the society through a significant contribution at the cutting edge of dental research. I congratulate all the faculty of dentistry and especially the hard work for their devotion and dedication, especially Professor Feroz Ali Kalodo and Dr. Amir Bhatt for arranging such wonderful, excellent scientific conference. I wish all the delegates a comfortable stay and our traditional hospitality, and finally the safe return to their destination. Thank you very much. Allah Hafiz. Pakistan Zindabad.
Thank you so much, sir. Now, I will request the worthy President of Pakistan Medical Commission and former Vice Chancellor, Liaquat University of Medical and Health Sciences, Professor Naushad Ahmad Sheikh, to kindly come and deliver his address.
Bismillahirrahmanirrahim. Ujan Saab, the Vice Chancellor, Liaquat University, Farooq Saab, Vice Chancellor from Sakran, my friend Feroz Kalodo, because of him I'm today here. Because I entered in LUMHS, I've seen him like this. He has not changed. And he was the dean since first day, till now, he's the dean. All my colleagues sitting on the Amir Bhatt, who has organized a wonderful this international conference. All my colleagues from professors, Dr. Anila Taraman, and my dear faculty members. It's really a great day today for me. And thank you so much for inviting me in LUMHS, because whenever I come to LUMHS, I feel like I have reached to my native place. Because this is the place where I served the longest period, where I got the love, where I got everything in my life, was the Liaquat University of Medical and Sciences. तो दीन साहब जो तकरीर जो आपने दी है, मैं इतनी पढ़ूंगा तो मेरा ख्याल है कि जुम्मे की नमाज भी मुझे यहीं पढ़ानी पड़ेगी सबको. इसको छोड़ते हैं. Come to the point. Okay, thank you all the delegates who have come all the way from Pakistan and internationally, or they have come here to share the ideas, to transfer the knowledge, to exchange the technology. I think these are the great days where you meet each other and you learn many things. It's not the simply functions or and the dinners and galas, but it's the learning spot where you come. Regarding dentistry, I always loved the dentist, because whenever I was a vice chancellor, dental department called me, I was the first person to reach there. The students of dentistry are really I've seen, they have a really enjoyable life, and they are a viable thinking how to move ahead in life. So I must say the students has they have a great motivation to develop, and dentistry nowadays is a very important subject. आप देखें दुनिया में सबसे ज़्यादा इस वक्त जो है डिमांड और अर्निंग जितनी डेंटिस्ट हो किसी को भी नहीं है. तो डेंटिस्ट, यू आर लकी दैट यू आर इन डेंटिस्ट्री, एंड शॉर्ट टर्म में माशाल्लाह बहुत अच्छी डेवलपमेंट हो जाती है. Regarding LUMHS, I'm really happy to see today Bilawal Medical College. I've been there. Thank you for showing me this. I think this was the real good decision which I've made in my life, was the Bilawal Medical College for the boys. And it is such a wonderful college now. If you see it now, then you can realize that you will not find anywhere in Pakistan like Bilawal Medical College. So now the people have realized this thing, that Bilawal Medical College for boys is the need of the time, and now they are developing throughout Pakistan the medical colleges for the boys. So inshallah, I hope that the dental college was also my dream, as Feroz Karor told me, and I pointed out the place where we have to make the dental college. And I'm hopeful this Ujan Saab will definitely. Now he started so many jobs here. I've seen different construction works, that he must do something for the dental college. And next time we'll come, we'll have another dental college in the LUMHS. Regarding PMC now, PMC, everywhere I go, people ask me whether you are a PMC or a PMDC. I'm a little confused myself what I am. So, आज मुबारक दिए इन्होंने मुझे, जबकि टाइम ख़त्म होने वाला है PMC का. So, I'm a PMC. I have been called especially for the interim period. I must clarify everybody. I have been called especially for interim period to convert the PMC to PMDC. So my role will remain till I establish the PMDC again, because since 1962 we had the PMDC. Now only 2 years back they have changed in PMC, which is a little harder and looks like a commission on us doctors. There are so many strict rules for the doctors, for the medical colleges, for the hospitals. So it's very difficult to survive with the PMC. So I have met the bill is gone, it is passed through the Senate, passed through the National Assembly, now lying with the President. As soon as President will sign the bill, the PMC will finish and PMDC will be, rebirth of the PMDC will take away. So my job will be till the PMDC is established, and inshallah, by that time, I'm trying my best, whatever I can do for my own doctors, students, and my institutes, hospital, I'm trying my best to change the rules, to facilitate, because I believe in one thing. Allah कहता है कि अगर आप दूसरों के लिए आसानियाँ पैदा करें तो आपके लिए भी आसानियाँ पैदा होती हैं. So I do my best to facilitate everyone. You can see in 2 months' time, whatever the changes in PMC I made. I'll not take you more time because we have to go for the Jummah prayers as well. So that is also a visible change we have done in the PMC regarding, if you see the licensing simple, we used to have only 2 years license. I said the doctors have no more time. Every 2 years they come again for the licensing. I made it for 5 years. Now you will apply, you will get the 5 years license. The basic sciences degrees, all teachers sitting here, the basic sciences degrees were not being recognized by the PMC. They said, we will only recognize your MBBS degree, you go for the basic sciences to HEC. So this was very, very difficult for the doctors. So I said, from now, every basic sciences degree will be registered in the PMC, and then the same registration, they'll get the degrees. So now it's started. Anybody who has been, they used to delete the basic sciences degree from there. So which is now started, and now you can do this. So like this, so many other jobs I've done in short period of time for the betterment of our own community. I know I belong to you, I have to come back to you. That's why I need that I should do something good for the doctors, for the students, and curriculum, we have been changed, making a good curriculum. Regarding admissions, MD-CAT is nowadays a big, you can say it's a big problem for the students, but I can't help it because 2,05,000 students appeared for the MD-CAT throughout Pakistan. I'm talking of the Pakistan. 2,05,000 students appeared for MD-CAT, and only we have 21,000 seats. I can accommodate 10% of the students who appeared. So of course, 1,90,000 students, they will not be able to get the admissions. So we have to make them mentally prepared because everybody hopes that we should get admission. Everybody's family hopes that we should get the admission. But I always say this, you should be mentally prepared. You got my point. Out of 2,05,000, only 20,000 will get the admission. 1,90,000 students have to choose some other field. So it has to be mentally and psychologically prepare yourself and your families that we have to do something else than to be the doctor. I'm sorry for this because I'm now trying to increase the seats as well. I don't want that my students should go Afghanistan, go Iran for the education, go to China, Russia. They should study here. So my basic, now I'm trying that the more and more medical colleges should open here, but there should be no compromise in the standard, and I should increase the seats of the already existing medical and dental colleges. I'll not take you more time, but I'm grateful for the organizers that they have organized such a wonderful event. So inshallah, these type of the events will keep on going in LUMHS, and Liaquat University has a history. Always they keep these types of functions and wonderful and successful events. Thank you, Ujan Saab, and everyone who's with me here. Well, I'll say in the last that please work hard for your country, for your province, and for your family and yourself. God will help you. Allah Hafiz. Pakistan Pindabad.
हमें यकीन है निभाई है जिस तरह आपने चमन को ऐसी वफा कोई दे नहीं सकता ये आरज़ू है हमारी आपकी ज़िंदगी के लिए दुआ वो दें जो दुआ कोई दे नहीं सकता
Thank you so much, sir, for being here with us.
Ladies and gentlemen, it is said, tradition does not mean a dead town. It does not mean that livings are dead, but the dead are alive. Following our tradition, now it's the time for souvenir decoration. I would like to request Professor Ikramuddin Ujjan, Professor Dr. Firoz Ali Kalhoro, and Professor Dr. Amir Mahmood Bhatt. Sir, please kindly come forward and present souvenir to our worthy chief guests.
Now, I would like to request our worthy chief guest, Professor Naushad Ahmed Sheikh, to come forward and please receive your souvenir. Sir, we are grateful to have you with us today. Thank you so much, sir.
Now, I would request our special guest, Professor Mahmood Farooq, kindly come forward and please receive your souvenir.
Now, I would request our special guest, Professor Nadia Yazani, kindly come on forward and please receive your souvenir.
Now, I would request our special guest, Professor Dr. Ambreen Afzal. Ma'am, kindly come forward and please receive your souvenir.
Now, I would request Professor Riaz Ahmed Waraj to please come forward and receive your souvenir.
Last but not least, I would like to request Professor Maqsood Ahmed Sumro. Sir, please kindly come forward and receive your souvenir.
Now, I would like to request our worthy Dean of Dentistry kindly present souvenir to our Honorable Chief Guest, Professor Dr. Ikramuddin Ujjan.
Yes, sir. And now, we will do the honor of presenting souvenirs to the respected speakers of our first session. I would like to request Professor Nazia Yazdani. Please, ma'am, come forward and receive your souvenir award. Ma'am, please come forward.
Now, I would like to request Professor Shade Ahmed Musa to please come on stage and receive your souvenir.
Now, I would like to request Professor Dr. Adil Abushak. Sir, please come on stage and receive your souvenir award.
Now, I would like to request Professor Amreen Afzal Hassan to please come forward on stage and receive your souvenir.
Now, I would like to call Professor Shahid Parvez. Sir, please come upon stage and receive your award. सब कुछ हो जाए, ये सारे फाइल हो जाए, सब कुछ हो जाए, बस आपने बोलना है प्लीज टेक योर रिस्पेक्टिव सीट. अभी नहीं, अभी जब मैं कहूँ ना यूं करूँगी.
Thank you so much, sir. Now you all may take your respective seats.
This brings to end of this inaugural session, and now we would take prayers and lunch break. I would request worthy chief guest and honorable special guest, please come forward to the part of rope cutting ceremony of inauguration of trade exhibition. आप जाओ. अच्छा बस जाऊँ ना मैं. हाँ हाँ जाओ.